This is the second part of the lecture of diabetes mellitus. The first lecture we spoke about the introduction, physiology and pathophysiology, classification and diagnosis, and how to evaluate a diabetic patient. A very important and very crucial part in the management of diabetes is the therapeutic goals. In other words, sometimes the patient might ask you what is the optimum level of the blood glucose at which I would say that I am a controlled case of diabetes. This is a very important question that you need to answer. First, you have to achieve A1C less than 7. The fasting or the preprandial blood glucose should be somewhere between 70 and 130 milligrams. Postprandial or the peak after meal blood glucose level should not exceed 180. Now remember that type 2 diabetes, usually those patients are overweight and hypertensive and they are having hyperlipidemia. So if you are having a diabetic patient who is hypertensive, the blood pressure, the optimum level should not exceed 130/80. The LDL cholesterol should not exceed 100 milligram per deciliter. The triglycerides should not exceed 150. And regarding the HDL cholesterol, which is the protective type of cholesterol, should be more than 45 milligram per deciliter. Now we need to speak in more details about type 1 diabetes. Type 1 diabetes, it is characterized by the fact that it has a long preclinical phase. And sometimes the onset or the start of symptomatology of type 1 diabetes, it can be precipitated by illness or infection, or even sometimes the stress. For example, for the school children, the onset of diabetes can be precipitated by the school exams. And usually the presentation of type 1 diabetes is truly explosive, and the symptoms are very apparent in the form of polyuria, polydipsia, weight loss, and fatigue. Sometimes the onset of diabetes can be presented by diabetic ketoacidosis. In other words, the first presentation of diabetes type 1, it can be by diabetic ketoacidosis. And it was observed that the onset of diabetes is actually having a high incidence during the winter time. And this is explained by the fact that during winter there is a high prevalence of viral infections, and as we shall see, viral infections actually it can contribute to the immune-mediated destructive process of the pancreatic beta cells in type 1 diabetes. Also, a related finding is the coincidence of type 1 diabetes with puberty, because with puberty there is increase in the sex hormones, and all these are counter-insulin hormones. This is a very interesting diagram which represents that the pathogenesis of type 1 diabetes actually it is presenting an interaction between genetic, environmental, and autoimmune disorders collectively acting, which will finally end into the process of immune mediated destruction of the pancreatic beta cells. And it was actually a recent classification for type 1 diabetes is the stages through which the disease passes. We have here stage 1 and stage 2 and stage 3. And as you can see here in stage 1, this is stage 1, it is characterized by the presence of multiple antibodies, but the blood glucose level is not yet altered and the symptoms are actually minimal. And stage 2, in stage 2 of type 1 diabetes, it is also here, this is the stage 2. In stage 2, there are multiplicity of autoantibodies, and this is the start of altered glucose metabolism, or what we call dysglycemia. But also the patient at this stage is not symptomatizing. And finally, we go through stage 3. In stage 3 here, the diabetes is established and the symptoms are very apparent, and diabetes is diagnosed by the standard criteria. Now, what characterizes type 1 diabetes? So long as we understand that the whole process of type 1 diabetes, there is a complete destruction of the pancreatic beta cells and there is no production of insulin, which means that the primary treatment, the only treatment for type 1 diabetes is lifelong insulin replacement. And with the use of insulin, we are aiming at two objectives. The short-term objective is to achieve a well control of diabetes or to optimize the metabolic control, and a very important objective is the long-term objective, which is prevention of the complications, because the morbidity and mortality of diabetes, it is related to the complications, namely retinopathy and nephropathy. Now, so long as we are talking about type 1 diabetes and the necessity to initiate insulin, we need to speak about insulin in itself. Number one, what are the indications for initiating insulin therapy in diabetes? It's needless to say that you need to give insulin for all types, for all patients with type 1 diabetes, and in certain cases in type 2 diabetes, if you give them oral hypoglycemic drugs but you have failure to control the blood sugar. And we have here an interesting entity which is actually the most drastic complication of diabetes, or the most drastic metabolic decompensation of diabetes, which is called diabetic ketoacidosis and hyperosmolar non-ketotic syndrome. And another important indication for initiating insulin is certain cases of type 2 diabetes when they are hospitalized in preparation for surgery. And sometimes we admit cases with type 2 diabetes when they are having very high blood glucose, because in such a case we need to administer insulin. And of course, a very important indication for insulin therapy is pregnancy. Now, this drags us to the related point, which is what are the indications for hospitalizations? In other words, when you are having a diabetic patient, when you should decide that this patient should be hospitalized and he should not be treated on an outpatient basis. Number one, diabetic ketoacidosis. All cases of diabetic ketoacidosis should be managed at hospital. A similar metabolic decompensation which occurs in type 2 diabetes is hyperosmolar non-ketotic syndrome, and of course all cases of hypoglycemia. The indication for admission of diabetic patients in a hospital, it's not only related to hyperglycemia, but also all hypoglycemic patients should be admitted. And we need to admit all cases, newly diagnosed cases of type 1 diabetes and gestational diabetes. And the reason for this, all cases of type 1 diabetes, you are going to be initiating insulin therapy, and this intensified insulin therapy should be done at hospital, not on outpatient basis. Now, we need to understand what are the various classifications, or what are the different types of insulins. The various types of insulins, actually, they are divided according to the onset of action and according to the duration of action. We have here an important category which is called basal insulins. And this basal insulin type, we call them basal insulins because they actually are having a long half-life and a very steady state of, as we shall see later on, the curve for the basal insulin, it's actually a flat curve. The basal insulins include the glargine and detemir and degludec. These insulins are characterized by having that the peak effects, it takes a long time, and the duration of action, actually, if you can see here, for example, insulin glargine, the duration is almost 24 hours, and degludec, which is the new type of insulin, the duration is almost 40 hours. So these are the basal. The other types of insulin, we call them the prandial or the short-acting, and we call them the short-acting because actually if you see the kinetics here, that the onset of action is 15 minutes and it reaches the peak within 45 minutes, and it lasts only for 2 to 4 hours. So this type of insulin, which is the prandial insulin, it's quite suitable to be administered just before meals in order to control the increase in the blood glucose which occurs after meals. This is another diagram which represents the kinetics of the various types of insulin. We have here in the yellow curve, it is representing the short-acting insulins, and the blue curve is representing the rapidly acting insulin, and the green curve is representing the intermediate acting insulins. Now, if you have look on these three curves, the yellow, the blue, and the green, you will find that all these curves, they have a peak. In other words, sometimes when the patient is receiving overdose, he can pass into hypoglycemia if he is receiving a dose of insulin and he is not eating, or if the dose of insulin is more than what is needed. But have a look here on the orange curve. The orange curve, which is the basal insulin, is a truly flat curve. So this type of insulin, which is called the basal insulin, number one, it has a very long half-life and it doesn't have a peak. The curve is entirely flat, which means there is an most unlikely possibility that the patient, when he is receiving basal insulin, to experience an episode of hypoglycemia. Now, insulin protocols. What is meant by insulin protocols? By insulin protocols, we mean what are the various methods to administer insulin for either type 1 or type 2 diabetes. We have here three major insulin protocols: the basal bolus method, the split regimen method, and finally the continuous infusion or the insulin pump methods. To understand the basal bolus methods, let's have a look on a normal physiology in a normal person who is not diabetic. Now, have a look here on the insulin secretion. When you have a look here on the insulin secretion, which is the basal insulin, you can see that the basal insulin is produced even in between meals whilst the person is fasting. The importance of the basal insulin is to maintain constant blood glucose level in between the meals. But during breakfast and lunch and dinner, in which the blood glucose increases after meals, there is a corresponding increase in the insulin secretion. So here you will find a match, and this match, as you can see here, I will highlight it for you. This match is between the basal insulin and the blood glucose. Now, during fasting, because you have a slow steady state of blood glucose, the insulin produced is actually a small amount produced by the pancreas. We call this the basal secretion. But when you eat here, have a look here, after breakfast and after lunch and after dinner, the blood glucose level increases. Correspondingly, the insulin produced by the pancreas will have 3 peaks matching with the increased blood glucose with each of these meals. So in the basal bolus method, which is the most popular method for treating type 1 diabetes, we are trying to simulate this normal pattern. So we are trying actually to match the blood glucose which increases after meals with the exogenously administered insulin. Have a look here on this diagram. This is the basal bolus methods. The basal bolus methods, you can see here, I will highlight it here for you. You can see here, we administer a basal dose of insulin glargine here. And the basal dose of insulin glargine, it is usually administered at night, and the aim of the basal dose of the insulin, of the long-acting insulin glargine, is to maintain the steady state or a constant blood glucose in between the meals. Remember that one cause of fasting hyperglycemia is enhanced gluconeogenesis. So you can say that the basal insulin in type 1 diabetes aims at suppressing the gluconeogenesis, which is responsible for elevation of the blood glucose in a diabetic patient during fasting. But here, during meals, you have here the breakfast, and you have lunch, and you have supper. In these timings of the meals, you need to administer a shortly acting insulin before breakfast, lunch, and supper in order to control the elevation of the blood glucose, which occurs after each of these 3 meals. A less popular method, which is called the split regimen method. The split regimen method, as the name denotes, the patient actually is receiving only 2 doses. Dose here before breakfast and a second dose before supper. And in each of these 3 doses, the patient is given a pre-mixed preparation. A pre-mixed meaning one single vial, it will contain a rapidly acting component. This rapidly acting component, which is the regular component, it will control the increase in the blood glucose after the meal, and the other component in the same syringe, it contains an intermediate, which is the NPH, which will continue to cover the time interval between the breakfast and the supper. And the second dose, which will be given before supper, it also contains a pre-mixed preparation of the regular and the NPH. The split regimen is less popular in treatment of type 1 diabetes, but it can be used in certain cases of type 2 diabetes. The third protocol is the continuous infusion, or what we call the insulin pump. The insulin pump is a device which is actually containing many components, including a rapidly acting insulin, and this device actually is composed of 3 parts. We have what we call the transmitter. The transmitter contains glucose sensor, a small needle which is piercing beneath the skin, and it will detect the blood glucose level. And once the blood glucose level is detected, it will send this information into the pump. There is a receiver here, and according to the received level of the blood glucose, it will actually pump as a calculated dose of insulin through the infusion site. This is the insulin pump, and sometimes we call this system the closed loop. So you have here the glucose sensor sending information to the pump, which will send the information into the infusion site. Apparently, this is an option for type 1 diabetes and not for type 2. And this is an image for an actual device of the insulin pump. Now, the most drastic complication of type 1 diabetes is diabetic ketoacidosis. What is diabetic ketoacidosis? Diabetic ketoacidosis is a form of a metabolic decompensation, and a similar metabolic decompensation which occurs in type 2 diabetes is called hyperosmolar hyperglycemic syndrome. Now, diabetic ketoacidosis, sometimes it is the initial presentation of type 1 diabetes, but the most important cause for diabetic ketoacidosis is infection, any type of infection, or inappropriate reduction of the insulin dose, or if the insulin dose is. So this diagram, it represents the collective metabolic complications of diabetes, the hyperglycemic states which occur in type 1, it's called diabetic ketoacidosis, and a corresponding situation occurs in type 2 diabetes, it is called hyperosmolar hyperglycemic states, and an important metabolic decompensation which occurs in both types of diabetes is hypoglycemia, and we shall discuss it in a separate lecture. Now, as we mentioned, the most important precipitating cause for diabetic ketoacidosis is infection, for example, like pneumonia, urinary tract infection, septicemia, or even severe gastroenteritis. And the second common cause is inadequate insulin treatments or a severe precipitating factor like myocardial ischemia or myocardial infarction. Now, diabetic ketoacidosis is characterized by a triad of hyperglycemia, ketosis, and acidosis. In type 1 diabetes, there is an absolute deficiency of insulin, which will enhance gluconeogenesis and glycogenolysis. Gluconeogenesis is the production of glucose from non-carbohydrate source. Glycogenolysis is breaking down of glycogen into glucose, and it will also enhance ketone body formation, because deficiency of insulin results in enhanced lipolysis and destruction or lipolysis of the triglycerides into fatty acids. Those fatty acids are going to deliver to form ketone bodies. So ketosis is the formation of ketone bodies by the liver. What are the ketone bodies? Acetone, acetoacetic acid, and beta-hydroxybutyric acid. The formation of ketone bodies, it results in ketosis or acidosis. Acidosis, as a defense mechanism, will be neutralized by the bicarbonate, which will result in depletion of the bicarbonate stores and resulting in metabolic acidosis. So remember, diabetic ketoacidosis is a triad of hyperglycemia, ketosis, and acidosis. And the clinical picture of diabetic ketoacidosis, it is characterized by an explosive onset, nausea, vomiting, polyuria, severe abdominal pain to the extent that sometimes diabetic ketoacidosis might be mistaken with acute appendicitis or any form of surgical acute abdomen. Physical signs, because the patient are usually dehydrated, so we will have tachycardia, dehydration, hypotension, tachypnea. Tachypnea is caused by the metabolic acidosis, because any patient with metabolic acidosis, there will be an increase in the respiratory rate in order to wash out the carbon dioxide to compensate for the drop in the pH. And this is a nice diagram which explains that the pathogenesis of diabetic ketoacidosis, what we have here, we have hyperglycemia here, and we have ketoacidosis. So the hyperglycemia is caused by increased production of glucose from the liver by enhancing gluconeogenesis, and diminished utilization of glucose by the peripheral tissues, ending in hyperglycemia, which will result in osmotic diuresis, and this will result in volume depletion. Ketoacidosis, it results from lipolysis and increase in the production of fatty acids going to the liver, increased production of ketone bodies. Ketoacidosis will result in metabolic acidosis and depletion of the alkali reserve, and eventually resulting in metabolic acidosis. Management of diabetic ketoacidosis. The most important and the most crucial item in managing diabetic ketoacidosis is fluid replacements. You have to resuscitate the patients by adequate fluid replacements. The second item will be reversal of the vicious circle by administration of intravenous insulin. A very important item in the management of diabetic ketoacidosis is the correction of electrolytes. Remember, when you correct diabetic ketoacidosis and as the glucose is enhanced to enter into the cell by insulin, it will drag potassium with it and results in hypokalemia. So after correction of diabetic ketoacidosis, many patients will suffer from hypokalemia, and if the physician is not alert about this hypokalemia can be life-threatening. So the items for management of diabetic ketoacidosis: number 1 on top of the list, fluid replacements; number 2, insulin treatments intravenous; number 3, correction of electrolyte disturbance, especially in hypokalemia. Usually, in spite of the fact that sometimes metabolic acidosis is very severe, but rarely bicarbonate is needed to be administered. And a very important thing, you have to treat the precipitating factor. If you are having infection, or if you recognize what was the precipitating factor which initiated diabetic ketoacidosis, you have to reverse this precipitating factor. Now we conclude this part, and the next part we will continue speaking about type 2 diabetes.